A toddler with a toothache and an adult doubled over in violent intestinal colic present entirely different physiological crises, yet both will likely be prescribed a drug carrying the exact same brand name, Meftal. Prescribing the wrong variant of this drug family is a critical clinical error. Handing the pediatric suspension to the adult colic patient will likely fail to resolve the spasm, while swapping them the other way around risks acute toxicity. This happens because Meftal operates as a modular system, with multiple variations all built upon a single base compound. To safely prescribe these medications, we have to look past the branding, isolate the base chemical, and map exactly how different adjunctive components are swapped in to target specific physiological failures. This shift in thinking allows a clinician to move past the rote memorization of brand names and begin matching the specific chemical combination to the patient's underlying condition. We start with this central block, mefenamic acid, formulated as Meftal 500. This NSAID manages baseline symptoms, generic fevers, headaches, and dysmenorrhea. It physically obstructs the COX enzyme, blocking production of prostaglandins, the specific lipids signaling pain and inflammation. The standard regimen is 500 milligrams taken 2 to 3 times a day. Because of its caustic nature on the stomach lining, it must strictly be taken after a meal to avoid gastric irritation. While this mefenamic acid base layer handles localized inflammation, it often lacks the power to break extreme systemic fevers or halt violent smooth muscle spasms on its own. Addressing those requires secondary active ingredients. The first clinical failure point occurs during severe systemic responses, such as unyielding pediatric fevers or severe full-body aches, where mefenamic acid monotherapy is insufficient. To solve this, a second active ingredient is locked into the base, paracetamol. Combining an NSAID with paracetamol creates a clinical synergy that yields a compounded antipyretic effect to drop body temperature, alongside a reinforced analgesic effect for widespread pain. This combination is frequently used for severe fevers in children, formulated as a liquid suspension called Meftal P. It is calibrated by weight and age, starting at 1.5 to 2.5 milliliters for toddlers and scaling to 5 milliliters for 2 to 3-year-olds. For adults facing heavy-grade viral fevers or body pain, this exact same mefenamic acid and paracetamol combination is compressed into a solid tablet, marketed as Meftal Forte. Both formulations require a twice-daily regimen, and again must be taken after food to protect the gastrointestinal tract. Adding paracetamol recalibrates the base drug into a tool optimized specifically for extreme systemic inflammatory responses. However, the clinical requirement changes entirely when the crisis is violent intestinal colic, severe abdominal cramps, or acute dysmenorrhea. Here, the paracetamol combination is ineffective. It targets generalized inflammation, but it has no mechanism to stop involuntary smooth muscle from actively contracting. The formulation requires a complete shift. Paracetamol is removed, and a new agent, dicyclamine, is locked onto the base, creating Meftal Spaz. Dicyclamine serves a specific role as an anticholinergic and antispasmodic agent. It targets the specific site of the cramp, forcing the violently contracting smooth muscle in the intestines or the uterus to chemically relax. Because severe colic can be debilitating, this combination is engineered for rapid onset, typically providing relief to the patient within 5 minutes. Substituting the adjunct active pharmaceutical ingredient repurposes the medication from a systemic fever reducer into a rapid response smooth muscle relaxant. Even with the correct chemical combination, pain occasionally breaks through standard dosing protocols, such as in cases of severe post-surgical trauma or intractable colic. This is the role of the DS, or double-strength, formulations. A DS variant does not alter the underlying chemical mechanism. It simply doubles the quantitative concentration of the active ingredients within a single dose. These higher-strength variants are reserved for severe post-injury trauma and moderate to severe pain that does not respond to baseline therapy. The dosing protocol here requires careful adjustment. While the baseline remains twice daily, it must be modulated based on the patient's severity and tolerance to avoid overdose. Concentration scaling is the final variable in this lineup, allowing clinicians to match the exact intensity of the symptom without changing their primary chemical strategy. Utilizing these potent NSAID combinations carries inherent systemic risks. Since all variants share a mefenamic acid base, family-wide contraindications apply. Patients with peptic ulcers or severe renal impairment are barred. The drug risks causing gastric irritation and elevating liver enzymes, effects severely exacerbated by hepatic disease or alcohol abuse. Furthermore, its mechanism for halting prostaglandin synthesis makes it prohibited during the late trimester of pregnancy. Ignoring these baseline NSAID guardrails can result in the medication acting as a systemic toxin rather than a therapeutic tool. There are also adjunct-specific contraindications, risks that apply to one version of the drug but not the others. For example, Meftal spas carried a critical, unique warning: glaucoma. This restriction exists entirely because dicyclamine's anticholinergic properties dangerously increase intraocular pressure. Administering Meftal spas to a glaucoma patient risks causing acute vision loss. The clinical decision is based on a clear distinction. Generalized fever and body pain require paracetamol adjuncts, while visceral smooth muscle spasms require dicyclamine adjuncts. Ultimate clinical precision and patient safety come from mastering the specific chemical combinations used across all these different formulations.